Now, hello and welcome to Globalsportscare. My name is Dr. Markus Laupheimer, and I have today a very good friend and a very good physiotherapist to interview, Dr. Enda King. He's currently the Chief of Performance and Rehabilitation at Aspetar Hospital. Hello, Enda.
Hi, Markus. How are you?
I'm very well, thank you. And today we're going to get at a special subject is, do we need an operation for ACL tear or not? Can we do it conservatively? And can you tell us a little bit about you and why I've chosen you to do this, answer this question?
Yeah, I currently have my role as head of elite performance and development in Aspetar. I'm involved in the development of our clinical pathways, primarily around ACL rehabilitation, but across other lower limb injuries predominantly. I'm involved in development of our staff and their education protocol, and then obviously managing some international athletes, a lot of whom have ACL injury. My background, apart from having qualifications in physiotherapy and strength and conditioning, I did my PhD in biomechanics after ACL reconstruction. So I have a great interest in the area and the outcomes and the various strategies about how we can help our patients best recover from what is not an unsubstantial injury.
Yes, and let's get straight to the subject. So I have, as a sports medicine doctor, I've got these patients who are active and then come to you and say, doctor, do I really need to have my ACL repaired? So which people do you think can be treated well conservatively? And then on the other hand, which ones do you think do require surgery?
Yeah, I think the primary indication for surgery is an unstable knee. So the question obviously is, are you stable in what you're going back to? So regardless, some people often make this an non-athletic question, but actually some people are unstable during activities of daily living. And so I think the number one question, obviously, are you unstable or will you be unstable in the activities that you're going back to? Now, the reality is that the ACL controls anterior translation and rotation. So it's very much challenged by strong deceleration and pivoting motions. So if you're not going back to activities that have strong deceleration and pivoting motions, the demands that the ACL would naturally protect against may not be relevant to your case and to your presentation. So I think those that are going back to, very sedentary activities, those that have a stable knee during activities of daily living, I think there's very good evidence to suggest that they may be and do manage very, very well with conservative management of ACL. And while we often think of ACL reconstruction as necessary to restore stability to the knee, which it does, it's also a second insult to the knee. And very often those that suffer ACL injury that are sedentary populations, they are not going back to high level activities. They don't necessarily have a great training history. They're not used to being in the gym and perhaps, being able to apply themselves with work and family and other commitments to the training that's required to recover not only from injury, but also from surgery as well. So I think there's very good evidence that they can do really, really well with conservative management. And I think even with conservative management, all we need to ask ourselves, are we saying, can they be stable despite the fact that they're ACL deficient, or are they a candidate for ACL healing? We know there's a lot of research coming from Australia currently about the ability of the ACL to reconstruct it or to heal. That research is very much in the early stages, and I'm not as well placed as the authors, Stephanie Philby and Jane Rooney, to speak specifically to the exact findings within their current research, but they're rolling out ongoing cohort analysis. It seems like about a third of ACL reconstructions, ACL injuries are suitable to have the necessary proximity of the ends of the ruptured ACL to go on then with the bracing protocol that they've developed to heal and restore normal stability within the joint. And I'm not sure when I say normal laxity, but certainly an intact and a competent ACL. So I think within conservative management, there's also important to differentiate between that. Well, are we looking for healing, or are we looking for someone to manage with a deficient ACL in their knee?
So I think the question, you say pivoting sports. So if you have a 38-year-old recreational football player who has done his ACL and only plays once a week, maybe some football with some mates. Would you say straight away after you've injured it, you need a repair? Or would you say give it a go for rehabilitation first?
Yeah, it's a really interesting point. So I almost think the frequency of play doesn't really matter. If you're pivoting, you're pivoting. Whether you're pivoting 3 times a week or 1 time a week, you only need to get caught out once. I think the second thing is, I mean, in any question of someone's going for surgery is, can you commit to what's required afterwards? You know, independent of what the activity they're going back to. There are people playing at the highest level of sport that are ACL deficient. Not only in terms of heel ACL, but actually ACL deficient. So we know that people can participate at the highest level, and they've come across my desk as well. But they are in the minority. The vast majority who attempt at higher level, whatever we'll talk about, the 38-year-old in a second, the vast majority that attempt at higher level to go back to their sport normally have another episode of instability and are unable to function. So I think the why would you not trial a conservative management? The only reason you may not trial it is that, you know, how will you know if you failed or not? You failed when you have another unstable episode. And the question then becomes, what's the consequence of that unstable episode? So do you do additional meniscal damage? Do you do additional chondral damage? So when I am, you know, would I, as someone that's a little bit older than the 38-year-old that you described, if I'm going back playing paddle and playing a little sport, would I have my ACL reconstructed now? I think I probably would, just to see what the process was like professionally. But I think I could modify my activities probably to, if my knee had sufficient stability to not bother. Golf is the primary sport now, so that's not necessarily a requirement. But I think if I was looking to go back to playing pivoting sports, there's a high risk that I wouldn't be able to. And it's interesting, even when you say, Marcus, like people say, you know, I play tennis regularly, and I have no ACL, or I play paddle regularly. But they're the same people that would also tell you that they have one episode of instability every 4 months, and their knee has an infusion, you know, every third month. So, you know, it's one thing in getting away with it, but I would. What do you call a coper? Is a coper someone who, you know, has a normal lifestyle, or is a coper someone who can manage and put up with the symptoms that they have in the evolution of what they're doing? So I think that there's no, I think when we're someone that, my general rule of thumb now is, if you're not going back to pivoting sports, it's highly sensible to have conservative management. If you are going back to pivoting sports recreationally, if you can't commit to surgery, I can understand why we would give a conservative management trial. If you can't commit to the rehab that's needed afterwards, but there is a chance that you will do further damage to the knee joint, and then you have to decide if that's a risk that you're willing to take.
So you actually already answered one of my other questions. So the other example would be the same age, but doing triathlon. You would give it a conservative try.
I think, you know, I've had a couple of triathletes that have had ACL injury falling off their bike, ironically enough, of all things. When you look swim, cycle, run, providing they've been inherently stable, and it does depend a little bit on the stability of the meniscus as well, because the medial meniscus is important for that anterior translation stability. But a lot of them are able to cope. I would be keeping a very close eye on recurrent knee effusions. But a lot of them are able to cope very, very well with conservative management, and certainly it would be appropriate to trial that without issue or without concern.
Yeah, I've got actually an example of a high elite level triathlete who had a little bit of knee pain, and they did bilateral MRI scans, and she didn't have any ACL, which probably was there for years, and she was doing
There you go.
European level triathlon. Yeah. So now I think the next question is, you know, if you, whatever road you choose, you say, you know, you need the commitment to do the strengthening. You know, how long would you say for somebody, let's say the triathlete who wants to try and do his conservative treatment, how long of a time frame does he need to go back to his sport?
Yeah, so I think, let's say we're going with an ACL deficient knee, and that's very much led by how happy the knee is. When someone has an ACL injury, some of them have very angry knees, massive effusion, a lot of atrophy, a lot of weakness, and that will take time to settle down and develop up. Some have very innocuous mechanisms, and you look at the knee, you think there's no way that person has had an ACL injury, and they go and scan and it's gone. So I think you're looking for a knee that's dry, a knee that's strong, whatever strong enough is, a knee that has a level of competency. Probably, let's say for triathlete, you probably need to be able to jump and land. Running is hopping from one foot to the other, so they need some kind of plyometric competency. And if you achieve that in a 3-month period, why would I not go back to my sport? There's no reason not to go back to your sport. We're not waiting for anything to heal. We're not waiting, but the knee is happy, stable, and you're functioning well, then that's appropriate. I know with the bracing protocols, they have a very clear timeline about how that for the first 12 weeks, the knee flexion angle changes. Their recovery and return time is somewhere around 7 months, but don't quote me too strongly on that. So it's not dissimilar completely to an ACL rehab, an ACL reconstruction rehab. And then when you have a reconstruction, again, it depends a lot on the level of trauma during surgery, the level of inhibition and stiffness afterwards. Graft selection kind of less so, even though a hamstring graft matures, at least in the research, a little bit slower than a patellar tendon graft. But have you had meniscal repair or period non-weight bearing afterwards? They will all have a ripple effect. What you do find though sometimes is that our general population compare themselves to the elite population, and so the general population will see a European footballer return to training in about 7 months and return to match at around about 9 months, and they will assume they're naturally going to do the same thing, despite the fact that the European footballer is training 5-6 times a week. Probably is having 5 hours of care per day. Probably is seeing a world-class surgeon. Not that all surgeons are world-class, but some see a higher volume than see others, and so it's a little inappropriate with me training twice a week to say I'm going to get back as far as quickly as one of the Champions League players. So I think that has to be taken into account, and again is very much driven by recovery of function, happiness of the knee, those kind of things, which every member of the general population, even if you could only train 2-3 times a week, will be expecting to make a full physical recovery in 12 months. Those that can be very accelerated and aggressive at their rehabilitation, you're probably looking between to matches between 7 and 9 months.
Okay, great. And we already started discussing before the interview a little bit about the literature. What causes arthritis, or more arthritis, having ACL reconstructed or having conservative treatment? What do you think about that?
Yeah, I think, what does the research say? The research says the level of arthritis is the same regardless of whether you have your ACL reconstructed or not. The research is fairly definitive of that, at least to my knowledge. I think there's a couple of things that we need to consider within that. By and large, those that are having a reconstruction are going back to higher levels of activities. So they're driving the car that little bit harder. So if we're comparing someone who's not going back to high level activities and they're driving their car at 30 kilometers an hour, and you're someone who's going back to play rugby, football, pivoting sports, who's driving their car at 100 miles an hour, it makes sense that the joint that's going back to those higher demand activities is going to have to absorb and tolerate higher forces. So I don't think the research has been done in comparing similar loading over a 5-10 year period in those that have only conservative or reconstruction. But also I think, in terms of what drives that, I think that the amount of bony bruising and the magnitude of the pivoting injury at the time, it's clear that meniscal damage has and meniscectomy, if required, has a very, very accelerated contribution to make to degenerative change in the knee joint. I think from a rehabilitation point of view, we know that infusion creates an environment that's hostile for cartilage. It doesn't create a normal atmosphere and ambience for cartilage to thrive. It softens the cartilage. So I think regardless, loading strategies will obviously influence changes over time. I think creating as much homeostasis in the knee, a dry knee with good strength and function will best help them. But to date, the research would say it doesn't really matter what, having a reconstruction is not going to slow down your rate of arthritic development. But then again, how much of that is because when you have a reconstruction, many times you go back to higher level activities. So lots of unknowns, but I think prevention is better than cure, and preservation of the meniscus is incredibly important.
Okay, thank you. So I think you answered most questions actually. So when I go through it, conservatively or not, have an operation if you're a high-level athlete and do pivoting sports. Think about an operation if you basically do pivoting sports on a higher level. If you do the pivoting sports only occasionally, think about maybe changing your activity or what you do. And conservatively, basically, for everyone who does sports in one direction and doesn't need a pivoting shift. And then obviously the exciting about the conservative treatment, maybe the Australians gonna show us how to heal it conservatively.
Yeah, and they have had athletes that go back with a healed ACL and go back to pivoting into man sports. And I mean, that would obviously be the dream outcome for all here. As I said, it's not, or at least to date, it doesn't seem like it's applicable to every ACL. I believe it's less than half, almost about a third, but don't hold me to that. And I think, you know, the big question often, and what I constantly get asked for higher level athletes is, you know, I heard about this person, you know, I know there's this guy playing Premier League or this guy playing NRL that has no ACL and is doing well. And that is true. But I think the reality is they are the minority. You know, the majority of people are unable to operate at that level. And what's the harm in trying conservative management? The only harm is that when you find out that you didn't cope, it often is associated with another big pivoting injury. And what additional meniscal and chondral injury happens at the time of that secondary pivoting. That doesn't mean you won't, if you have your ACL reconstructed, you won't re-rupture. But certainly the re-rupture numbers that we have in Aspetar and where I worked previously in the sports surgery clinic, they were, you know, below 4% at 5 years. So it's almost the contralateral healthy limb that's the one that's more likely to take the bullet second time round. So lots to consider, and like all these things, no one answer applicable to all.
Okay, thank you very much for your time. I think we say hello to all the followers. Please follow Globalsportscare on the YouTube channel, and I will also put a link onto the research we mentioned. And maybe we can see Enda in one of his courses, so don't forget to visit Enda's webpage to book him for his great courses. Thank you very much.
Thank you, Markus. Great to chat.